Michael, thank you very much. Thanks for those very, very kind words. I'm going to ask you to do it again. Make me feel good. Thanks very, very much. I'm sometimes asked what my connections are to Ireland. And my connection, I can actually sing Hail Glorious St. Patrick, dear Saint of our Isle, against Satan's wild, whatever. I can sing you the whole song. And that's because at school I went to Christian Brothers College in South Africa. So my teachers were brothers, were Irish brothers. And we got a very good schooling at the time there. And it was also, that it was quite unique in South Africa. There was a time of apartheid. The Catholic schools were despised by the government at the time because they were against apartheid, and they stood up for the values of love, the values of looking after each other, and we're all the same, respecting each other no matter what color, what language, what culture. And so the brothers did teach me that, and if it hadn't been for that, I think I'd have been living in a country where if you're born into something, you don't know anything different, right? So I'll always appreciate that of them. And then back in 2011, I think it was, or 2012, when there were some discussions going on about establishing the All Iron Institute, I was asked to be an external consultant. And so I came over. I've been to Stormont, so I feel really proud to have been in Stormont as well, because the meetings were there. And here we are. And I was looking recently through the website, and you folks have done an amazing job. Incredible job. The variety of activities going on. I mean, I think back to those first seeds back in 2011, 2012, and where you are now. It's incredible, and congrats to all of you. You've got to be very proud of what you've done. And in fact, the work, for example, of the grid, the competency grid, was adopted and adapted in Canada by the Nova Scotia Palliative Care Group. And that in turn generated similar type of activities across the other provinces of Canada. So your work has influenced and impacted the work in Canada. So well done. So I thought I'd start with a story. Last week I was asked to attend a meeting by a friend and a colleague called Carlos Shakur. Now, Carlos Shakur is not in palliative care at all. Carlos Shakur is infectious disease specialist and a public health specialist. And Carlos has done a lot of work around prevention and treatment of malaria, especially in Africa. And he's lived in Africa. His wife works in our Pallium project in Spain, because we're busy bringing the Pallium approach and the Pallium products over to Spain. And he said, Jose, I'd like you to come to a meeting because I want your insights in terms of the research. So here's the story. On the left, he published a cluster randomized trial in the New England Journal of Medicine, right? So it's a top journal, and published this just a few months ago. Within 4 or 5 days of publishing it, he received a letter from the editor saying, we've received a letter from someone, and I've blocked out the names of those two individuals who contest the findings. And so he read it, and what they said was something like, we commend Shakur for the randomized trial, blah, blah, blah. And then they said, but they overlooked some very key evidence, and they quoted Carlos Shakur's own studies, which he was very aware of, and they quote another study saying, and this other modeling contradicts, and it's also Shakur's work. So Carlos and his team we started looking through this, and what we discovered was that there are a group of about 20 individuals around the world who have now published hundreds of letters in 1 year to editors on all sorts of topics. This particular group that published this letter about Carlos's study have identified themselves as being in geriatrics. But they obviously know a lot about ivermectin and malaria treatment. And amongst these, you can see there's a very, very big increase, 23, 24, in the number of letters being published. So the question is, why all of a sudden are people who very seldom wrote these letters now publishing so many letters? And what's very bizarre is why they're publishing about orthopedics, pediatrics. I mean, you name it, and it's wide. We've got another table that shows how, this one group or two groups are publishing on different topics that you would think not aligned with their area of specialization. So what do you think is the reason? I mean, we postulate exactly. We think it's AI, and so the point here is that AI is here. It's arrived, and it's influencing us and affecting our work in many ways. And I think there are strengths, but I think we also need to understand the limitations of this innovation. And already, this was a paper that was published. This is not in healthcare, but in general, a study looking at scientific publications where more and more are now being written by AI. I don't see a problem with using AI to improve your language, to improve the content, but if it's being written by AI, there's plagiarism issues, there's professionalism issues, right? And so I think we've got to be aware of that. Websites now, I just saw a study 2 days ago, half of the websites now are being written by AI and not by humans as such. So I thought what I'd speak today is the arrival of AI and a little bit of a reflection on AI and the impact it's having on education and this innovation, which I think is a double-edged sword. It's got its strengths, but we may be cut by it as well. And then I thought I'd speak a little bit about traditional versus new, because we have a habit of throwing out in our quest for innovation, we sometimes reinvent the wheel and give it a different name. For example, hypodermoclysis. I remember I was working in Edmonton when Eduardo Pereira and we started using hypodermoclysis, and we were writing about hypodermoclysis, this new innovation. Well, lo and behold, it had already been done about a century before, using the quills of a feather to do hypodermoclysis. So it wasn't new, but we give it a different name and we call it innovation. And sometimes in the quest of innovation, we throw out what works well. So we throw the baby out with the bathwater. And then I just want to share some experiences around the use of humanities in games. And again, I'm not going to say it's an innovation because it's been around for a while, but I think that there are things that we can use there in education. Okay, so let's go on to the arrival of AI. I'm not going to spend much time in these initial slides. There are many different definitions for what AI is, and AI is this massive, big, it's an umbrella term for so many different components. And for me, the WHO Guidance on Ethics and AI definition of 2021 probably sums it up the best. AI refers to the ability of algorithms to mimic human cognition, including learning, reasoning, and self-correction, to perform tasks and solve problems. And that's just one of many, many different definitions, and it's changing. Do you know what happened in November 2022? The arrival of ChatGPT. So AI had been there before, but today in the medical education world, if you speak of AI, people immediately think of large language modeling, which is ChatGPT or some of these other LLMs, as they're called, large language models. So the definition is changing. So I thought, let me ask Perplexity. So Perplexity is one of these LLMs, large language models. So I thought, let me ask Perplexity, do you think AI is intelligent or not intelligent? So I'm asking it itself, and this is the response. Why today's AI isn't intelligent in the human sense. It's got no understanding, no reasoning or intent, no original thought, no experience. What it really is artificial impersonation, statistical pattern matching. And why do we call it AI? Because it's historical, and it goes back to the 1950s. The term artificial intelligence was coined in the 1950s. And then marketing and hype. And so Perplexity says, in practice, AI now refers to any system that automates tasks traditionally requiring human intelligence, even if it doesn't actually think. Now, interestingly, it said there, why today's AI? Because I think in the future we may see something quite different. In tomorrow's AI can be very different to today's AI. And for example, when we're looking at simulation, the standardized patients. And now we're beginning to explore virtual reality and AI augmented virtual reality to support communication training. I think we're still far from it being very good, but it's going to get there. Again, just very quickly as a background, there are many different types of AI. So there's machine learning. Large language models is just one component of machine learning, and there's things called deep learning, where deep learning is a type of machine learning that uses these networks, neural networks as they call them, to connect and process complex data. So if you've got many points, many data, and they try connected. A good example is they're beginning to now identify new medications and new drugs using AI, and I think that's where it's going to be really, really helpful for humankind in the future. There's natural language processing, computer vision, expert systems, etc. I'm not going to go into that in detail, just to say that there are many different types, and we often now think of it more just in terms of LLMs. And there are many different LLMs. So we've all heard of ChatGPT and the different versions of ChatGPT. There's Perplexity now. So Perplexity is one that is supposedly more focused on researchers and educators. And I've been trying it out. There's programs called programs such as Elicit. And then there are also a lot of these plugins. So some of these, like ChatGPT, and you can plug in these extra functions, these models that then help you in a certain area, such as referencing, etc. But we all know that they are not perfect. And they are liable to a lot of what they call hallucinating for the time being. So be very careful if you're going to be finding references, because they do sometimes hallucinate references, and I've seen that. Sorry. I don't have COVID, and I don't think I've got any infections. This is my allergies and my asthma. Yesterday was worse. I was working with Joanne and Mary, and it was really quite bad yesterday. Oops, sorry. Anyway, so the fact of the matter is that our students, our learners, are already using it. So in Navarra, at the University of Navarra 2 years ago, I gave a presentation on the roles of being a doctor, and used the CanMeds roles, so things such as scholarship and expert communication, collaborator, etc., etc. And at the end, I gave the students a task, and they were to do this and put it online. So they were to upload it to the learning management system that we use. And the task was, the slide said in Spanish, write a reflection of, oh, thank you, thanks very much, thank you, compassion. The slide said, write a reflection up to 500 words on how AI and new technologies can impact empathy and compassion. And the first 10 that I received seemed to be just almost too perfect for like first year medical students. So there's something bizarre going on here. I mean, obviously we already started suspecting this is like AI written. So I contacted a friend of mine who's an AI expert, and he put it through the machines, and it came back 95, 98% probably generated, but you can't be certain, right? So you'll be very careful. You cannot say this is generated by AI, because it's becoming very, very similar to what we can generate. So just be very careful. Never accuse someone of using AI when they haven't. Anyway, but it looked pretty obvious. So I went back to the class. I stopped it. I said, okay, look, I think that it was used, and there's not much point in us continuing with this project, or not project, with these reflections, because they're 4 marks. So let's try to turn this into something positive. So we formed a group that is going to explore the role of AI in medical education. So we formed a group of 25 students who volunteered to join us. And it's become a fantastic project. We've now got 3 papers published, and we're going to be publishing another one soon. And they've learned scholarship, and they've become very interested in doing research, from qualitative research to Delphi processes to scoping reviews. And one of the studies we did was we interviewed students in the first year medical class, and we asked them things such as, are you using AI? 17 of them were using it to varying degrees, some a lot, some much less. One was very skeptical, they're not sure, and there are two that said no ways, they're not going to use it. So we got a little bit of variety. And what's come back is obviously they're using it, and they're using it in different ways. So some of them use it to initiate their learning. So let's just say they've got to learn something about, I don't know, let's think of something, advanced care planning. So some of them will go to their LLM, be it Perplexity or ChatGPT or Elissa, whatever it is, and they'll put in there, tell us about, I'm a first year medical student, I need to learn about this, summarize it for me. And so they start their learning journey on a topic using AI. Others say, no, we first look at our lecture notes, we go to the lectures or the classes or the workshops, we then take those notes, we read it, we study it, we read through our prescribed textbooks, and then we'll go to AI or LLM if we need some clarification on something. Or others say they'll go to it to try summarize it. Okay. It worries me when they say they're going to start their whole learning journey on a topic with AI, because we do know that it could, at least for the time being, has got some hallucinations and may be incorrect. But I can understand why it's become very, very powerful tool for them to augment their learning and summarize things for them. And they find that it's flexible, and it can be very personalized. So they can go into as much depth as they want. So for their individual needs, it can be adapted for their individual needs. The other interesting way they're using it is that they ask it to generate questions, multiple choice questions, when they're studying for an exam. And they'll go and they'll generate questions, and then they will work on those and study, and they find that very useful. Now, here's a bit of an irony. What we also discovered was that the teachers are generating questions using AI. So it's actually AI testing AI, if you think about it. If AI is generating the questions and they're now being answered by AI, we've just got these two intermediates here, but it's actually AI that's connecting to itself. They are aware of some of the professionalism and ethical issues, plagiarism, for example, and they said, we would like guidance about that, and we want to learn about it. So it's here, and as educators, we've got to learn how to use it. We've got to learn how to do the prompts. I'm a neophyte still, and still learning on this, but it's here, and it can be very powerful. But we need to understand it, and we need to teach the students where its strengths are and where its weaknesses are. So for example, in one of the classes, I said to them, okay, I'm going to imagine there's a patient in front of you, and the patient says, the patient is a patient with very advanced pancreatic cancer. And the patient says, doctor, how long do I have to live? And here is my response, and I put the response up. My response was something to the effect of, that's a very important, I'm sure there must be a very important question for you. I'm so sorry that you're in this situation, but we are not God, and we cannot predict how long you have to live. But I'm here to help you, and we're here to help you with managing symptoms and make sure you're comfortable. To that effect, right? So you haven't actually answered the question. And we put it in, they put it into their whatever LLM they were using, and then we asked, okay, now what does it say? Excellent response, full of empathy, acknowledge the feeling of the other one, etc., etc. Nowhere does it say, but you haven't actually answered the question. Because the question is, how long do I have to live? And simply saying to someone, we have no idea, I think sometimes, I mean, that's true, we can put that as a caveat, saying, look, we're not very sure. And we sometimes get it wrong, and people live longer, people live shorter. But I think under the circumstances, what I'm seeing, etc., I think, we're looking at weeks to many weeks or months, something like that. But the students felt that, oh, this is a great response. So had they done that as part of their learning process, they would have missed a very important step in learning about communication and responding to that question. As part of this group of students, we also undertook a massive big scoping review. We did a scoping review of the use of AI in undergraduate medical education from 2020 till 2023. And as you can see, just after 2022, there's a massive increase in the number of publications around the use of AI in medical education. And there are different types. There are more studies, there are papers on perspectives, guidelines being published, overviews. So that has been generated, that massive big exponential increase has been generated by LLM, ChatGPT and these other LLMs. But it's interesting how it's being used. So in medical education, now I think a lot of this is applicable to nursing education and the other health professions. So it is being used as a learning tool. Students are using it, as we discovered in those interviews with the 20 students who said to us, we are using it and we're finding it generally useful. Some of us are aware of the limitations. And by the way, those 20 students with that study that we did, some of them were interviewed as part of the study. And one of the things that came back to us was the mere fact that they were involved in this project, learning about AI, in addition to the scholarship component. How do we do interviews? How do we do qualitative analyses? How do we do Delphis, etc.? They learned a lot about it, and they learned a lot about the limitations which they were unaware of before. Which says that we need to be educating ourselves as educators, but also students, on the appropriate, effective, and ethical and professional use of AI. But it's being used as a learning tool, very personalized, as we learned, case-based learning, people putting in cases, getting back the cases. Often pretty accurate, but every now and again some errors. I remember putting in one case there with the use of, and then it came back as morphine could be used by inhalation. And we know that we're no longer really using opioids or morphine inhalations for managing breathlessness. Generating learning content from the perspective of the educators, but also the students. Autonomous tutoring, simulation-based learning, generating tests and examinations, marking tests as well. A lot of there's been a big debate at the University of Navarra about the ethics of this. So if students write all these reflections, because a large component of medical training at the University of Navarra is reflection on things such as empathy, compassion, professionalism, etc. Is it fair that we're putting it through AI to do the marking? You put a grid, look for these component aspects, and if they're present, then you mark it correct. I started looking at mine, and in the year before last, we noticed that quite a few of them were obviously generated. Well, I can't say obviously. High likelihood that they were generated by AI itself. So you've got AI marking AI. So we've changed the reflections a lot. So the reflections are no longer give us a general reflection on the difference between empathy and compassion and how they're linked. Dignity, what is it? How can we enhance someone's sense of dignity? But rather provide an example of a patient, provide an example of an experience that you had during your clinical rotation. So we've now connected to the clinical rotations. Now there's something very important there. We've got to be absolutely sure that they do not divulge any personal information, because now you're putting it. Now we're using a AI platform that's secure within the university. It doesn't go out into ChatGPT, because if it does that, you've got a problem, because you could be divulging personal information. So we've got to train the students on how to write these things. Make sure, this is what means anonymizing it and securing privacy as you do these reflections. but the reflections have been have improved a lot. It's out of personal, less likely to be generated by ChatGPT or Perplexity. I'm still marking them by hand, but it's becoming very difficult, to be honest, in terms of going through 500 reflections. Okay. Self-assessment, we've already spoken about that, and then the whole area of procedural skills, communication skill training, etc. We're beginning to see the use of AI in palliative care, palliative and hospice care. Here's just one example, is the use of artificial intelligence, decision support tools for end-of-life care, planning conversations. There are more and more papers now about the use of artificial intelligence to support communication training, and I'll come back to that. If you look at AI platforms to help with the communication, there are a whole lot of them. There must be at least 12 to 14 on the market. And they include things like SimFlow, SimConverse. There are a whole lot of them. At the moment, I don't think I've seen, I don't know if any of you have seen ones where the avatar, imagine you're a student and in front of you is a computer and there's a virtual patient, and you're speaking to the patient. It's doing voice recognition, it's transcribing as you speak, and it's giving you feedback immediately afterwards. Those avatars are still very robotic, and I don't think we're anywhere near close to it really mimicking the real world, at least in that area. In other areas in medicine and nursing education, they're pretty advanced. I mean, for example, in anatomy, beautiful use of virtual reality and AI-enhanced virtual reality, where you can see the nerves and the variations in the blood vessels. Fantastic simulations around, for example, a critical care, a patient unstable in an emergency room. But in the area of communication training, it's largely related to text. So like I said earlier, you provide the text and then it responds, and you provide the text and it responds. But I think we're getting there. Things are improving quite rapidly. So in Pallium Canada, we've got the challenge. So we do about 700 to 800 courses a year across the country, across Canada. These are intense courses, as you'll see shortly, of 1 to 2 days on the palliative care approach. Primary care and healthcare professionals across various different specialties. Well, you cannot do a standardized patient training with so many courses. We don't have the time, we don't have the resources, the infrastructure to train actors and do the simulation. So we've got to try a different way. So we've been using videos, and if there's time, I might show you one of those videos. But I think increasingly now we're looking at AI as a possible solution for scalability. And so far, our experience has been it's beginning to work well with text, but we're still far away from the actual live, the fidelity of a real life interaction. So there are potential advantages with using these for communication training. Low stress environment, it's safe, you're not going to be causing any damage to a patient or family. There's automated feedback. It says enhanced realism. I think it's getting there, but it's still far from it. Empathy development. So it does give some good feedback in saying, if you use the following language, it might be more empathic than perhaps what you did or didn't do. In our case in Spain, for example, language support, because you can do Spanish, but in Spain there's Catalan, there is Galician, there's Castilian, there is Basque language, and so it's able to do the different languages. There are limitations, as I said, it's still very robotic. It misses lots of the non-verbal. So, when you're interacting with a patient and you put your hand on their shoulders, for example, it misses, it doesn't capture that. I'm quite sure in the future it's going to do that somehow. But for the time being, it doesn't do that. And it lacks a lot of the human nuances. So, in truly understanding the complex emotional and experiential aspects of the dialogue that we have with individuals, and those little phrases and the silence that we use sometimes. So this is a case where I don't think we can rely entirely on this new innovation. And we still need to go back, depending on the type of training there is, to simulated patients, or in our case with Pallium Canada, still using the videos, the evaluation showing it does help. It's not perfect, but it does help. Okay, and this whole thing about virtual reality now becoming more and more popular. This is a fascinating paper by, I think this group is out of Harvard, Christine Ritchie. And they published this paper recently, well, about 2.5 years ago, on serious illness conversations in practice. And what they said is the current state is patients get identified by clinicians, patients requiring a serious illness conversation. So the assumption there is that these clinicians will pick up on who these patients are who need this conversation. But obviously, you can imagine all the barriers that there are. Clinicians don't know what palliative care is, are afraid of initiating the discussions, don't recognize someone with palliative care needs, still perceive palliative care to be only the last days or weeks of life rather than much earlier. And so they describe this future state that's enhanced by AI. And so it's this multimodal approach wherein AI, through its models, identifies, and algorithms, identifies patients in a hospital who require serious illness conversations. So they get flagged. The clinicians get these prompts on what language they can be using, what strategies they can use to engage in these discussions. They can go in and record these discussions so they can give the recordings, the transcripts to the patient, but those very recordings and transcripts are then analyzed through AI to give feedback. This is what you did well, this is what could be improved. So I think that could be a reality, and I think we're not too far away from it. So an example of where it could be helpful. Now, another area we've used in Spain, one of the big, not a big, but a cultural difference between the Spanish Pallium project adaptation and Canada is that in Spain, it's very important to see an image of someone. And I would say my background is Portuguese, my name is Portuguese. As you can hear by my accent, I was born and raised in South Africa, but my background is Portuguese, my home language is Portuguese. And in Portugal as well, you've got that connection, right? So it's been God-sent, the AI, because we can generate these pictures. So there isn't anyone like this. These are generated by AI. They look very real. And so when we're doing case-based learning or problem-based learning, you've got a face to put to it, right? And you can age the face. You can age the person. You can get them thinner as they become cachectic in the process, through the illness. But it does get it wrong sometimes. And so we asked in this particular software program, we said, okay, please generate a picture for us of a patient sitting on a chair with his legs bent at the knee, his feet on the floor, with one hand resting on each knee, elbows pointing outward. So what we were thinking was something like this. Was someone with shortness of breath and going, well, this is what we got. And we were not able to generate the picture we wanted. And then we asked this one as well, a patient, a turtleneck sweater, no hair, no eyebrows, and this is what we got. So, not always perfect. Moving slightly away from, actually not entirely from education, because in education research, we do a lot of quantitative research, but also a lot of qualitative research and mixed methods, thankfully. With Pallium Canada, we've been exploring the use of LLMs to do qualitative analyses. exploring how accurate are these things. For example, in all the courses that we do, these 700 courses to over 9,000 healthcare professionals and care providers across the country every year, at the end of each course, they identify 3 to 4 things that they will do differently in their practice as a result of participating in the course. And we'll come back to that shortly. But that's generated now thousands and thousands and thousands. So if you want to analyze that, the traditional way of analyzing is you got to do sample some of them and then analyze the 123, and even 300 is a lot. So we thought, what if we put it through ChatGPT? And what we've learned is that ChatGPT can enhance it, but it doesn't replace it. And it still makes sense. It's more robust. As a researcher, you do the coding, you identify the codes and the themes, and then you maybe ask ChatGPT, do you see these elsewhere? Are there any other codes or themes that you're seeing? And we have picked up some others as we've analyzed, these thousands and thousands of commitments to change. These commitments to change at the end of the course, what would you be doing differently? So you're beginning to see AI coming into analyses, both quantitative and qualitative. For those of you, just show of hands, SPSS, the quantitative, right? And the language and the complexity of it. And well, it's now pretty easy going into ChatGPT and saying, this is what we want to do, give us the language, and it makes life a lot easier, and then we can always replicate it. So it is, I think we're going to see more of it. And in fact, some of the software programs that help us with qualitative analysis, for example, In Vivo, is now really got AI into it, and they're perfecting and improving AI. So I think AI is there to complement and not replace. And I think I've given you some examples of it. Good. So moving forward now, let's go to the concept of traditional versus new. You remember the days of written examinations? Well, some of you may. I see a lot of young faces here. You don't remember those days. But we used to be in a big examination hall, and everyone would have their papers. You would write it, and then we had to mark by hand. And then came these forms where you could color in multiple choice, A, B, C, D, E, and then you color it in your selection, and then we used to put it into what's it called? Not a printer, but a scanner, and then it would mark it for you. Do you remember those? Yeah. I think it was OCR or something, OCR technology. But now we've got computers, right? So students can bring in their laptops or sit at a computer in the computer labs, and then they do the examinations digitally, respond to the questions digitally, and it automatically gets marked, particularly multiple choice. We're talking about multiple choice here rather than short answers or essays. What we've discovered at the University of Navarra is that students are using AI in the background to respond to the questions. So guess what? We're going back to using paper-based exams. So the examinations now are, you come in and here's the paper and you've got to fill it in with the paper, do the multiple choice, and we're going back to maybe having to use this OCR technology to mark them again. And instead of telling them to post a workshop, let's say a workshop on compassion, do a reflection, and then upload it, at the workshop, the last 10 minutes are write your essay, a reflection now, handwritten. It's adding a lot of work to us in terms of having to collect it and mark it and going through. But we're still struggling to figure out how we're going to do this. I'm sure there are going to be solutions in the future that stop you from using AI to cheat. There was one experience that was sad, I guess. There's a professor, this was a few months ago, in one of the classes, I think it was an anatomy or physiology class, and said, okay, you're doing it on your laptop, but you may not use AI. And if I see anyone, if I catch them with AI, you fail, automatic fail. and he was walking up and down the aisles, and he's walking down one, and suddenly behind him he hears, "Yes, I can help you with that question." So the student had obviously forgotten to switch off the voice, and it was obviously AI. Oh, so the whole exam was cancelled, and there's this whole palaver about it, and we're trying to figure out at the school what we're going to do about it. So, simply because it's older or traditional doesn't mean that it doesn't work. And I sometimes wonder what we mean by traditional, because e-learning, there's this whole big thing around e-learning, right? E-learning, e-learning means lots of different things to different people, but e-learning in the sense of using the internet, for example, computers, we're looking to the 1980s, 1990s, especially towards the end of the 1990s, and it's become this big thing. But I would argue it's now traditional. It's not new anymore, it's traditional. So maybe we've got to throw out this language of traditional and new and innovative and not, and come to the realization that all these tools work in different situations and we can use them. And they should be in our toolbox, and we use the lecture when it's appropriate. We use an e-learning program. We use a simulated patient in real life when it's appropriate. We use a simulation when it's appropriate, rather than, trying to adapt the new all the time. The lecture, for example, the workshop, the lectures are still very, very, very effective, I would argue, if done well. And one of the best papers out there about this was written back in 2003 in the BMJ. There's a fantastic paper by Peter Cantillon about the ABC of learning and teaching medicine, teaching large groups, and it's a lecture, and it gives you some strategies on how to make a lecture effective. So lectures, I think, are still important, and there are strategies that we can use. He mentions things like chunking and narratives and analogies and metaphors in the lecture, comparing and contrasting, and then embedding educational media in a lecture. So lectures are not old. They can still be useful. A lecture can be far more effective than a poorly designed online e-learning program. It depends on how we design it and when and how we use it, I would argue. And we've had all this evolution of different methods, right, from the lecture to problem-based learning. So in the 1970s, the 1980s, starting at McMaster University in Canada and then Maastricht University in the Netherlands, PBL, this new thing of PBL. Well, way back, they were using this in medieval times and learning with the cases. And then we moved from, didn't quite move, but we added case-based learning because we discovered that PBL, very useful to achieve certain competencies or learning objectives, but not very efficient. Because PBL, in the true sense of the word, is you identify a problem. Okay, there's a problem. You then identify the questions. You go out and you study those questions. You work as a group. Each one gets assigned a specific aspect of that question. They come back and then they share that, and then they identify the new questions, go out and come back again. So very collaborative. And one of the strengths of PBL is that it nurtures self-learning and curiosity. What are the questions I need to answer? Need to go read up and learn more about this particular topic, but not very efficient. So if you've got a limited curriculum, you can't do this, and we often don't have enough tutors to be going into all these small groups. So case-based learning is where you've got cases, but the learning objectives are pre-assigned. You've really got the learning objectives. You've mapped out the case. And so in Palium Canada, for example, our LEAP courses use mainly case-based learning. And now the big thing is competency-based medical education. Just by show of hands, how many of you are involved with competency-based education? Yeah. Right, so changing how we look at it, how we assess students. It's more flexible. Some students may qualify in 4 years, others in 5 years, others in 3 years. A lot of logistics around it, but it's a big thing now. And as we said, we're not moving to, but we've got simulated, standardized patients, and now hopefully we can have some enhanced simulations that can help us more. Let's get to the topic now of classroom versus online learning, particularly in the area of continuing professional development. So for healthcare professionals who are already in practice. And so here I'm going to share with you a bit of a story and some experiences from Pallium Canada. So Pallium Canada has got several programs. One of them is Compassionate Communities, but the big program is LEAP. LEAP stands for Learning Essential Approaches to Palliative Care. And these are short, intense courses of about 8 to 16 hours. And over the years, we've asked ourselves the question, is that enough for someone to learn about palliative care? And some people can argue, no, it's not. Well, it is, to get you to recognize that palliative care is not just at the very end of life. Identify patients who need it, learn how to do assessment of patients, the holistic approach. And we've published evidence that it does have an impact. And if you're looking at large scale to train as many healthcare professionals as possible, we cannot rely on courses that are going for weeks and weeks. Those courses are very useful for like the second level, for people a bit more in depth, but just to change the culture in the healthcare system across all care settings, from nursing homes to community practice to hospitals to continuing care facilities and long-term care facilities. In order to change that culture, we need to train a lot of people on what we're talking about with palliative care. And I just experienced that about 1.5 years ago with my father-in-law. So my wife's family is from Fatima in Portugal. He was in a nursing home, and they did a great job caring for him until the last week or two of life. And we had said to them, it's going to reach a point where he's too weak to lift up the spoon. At that point, please feed him as long as he can swallow. But there'll be a time where as part of the dying process, he's not going to be swallowing anymore. And at that point, keep him comfortable. What did they do? They sent him into hospital, and they put a nasogastric feeding tube in him. He came back coughing, etc., and then tried to pull it out, and they tied him to the bed. And these were very loving people who had done a great job caring for him until that moment. We were fortunate. We got a phone call from a nurse who said, "Don't tell them I'm phoning you, but this is what's happening." So we got in the car and drove to Portugal and said, "Listen, take this out." And he was very comfortable for the last week of his life. But it illustrated for us the importance of everyone understanding these basic principles about palliative care. My father experienced the same thing last year. My father had moderate dementia with very advanced heart failure and very advanced renal impairment. Ended up in hospital with an incarcerated umbilical hernia. And he died from that. But he was screaming in pain. So I was trying to get a flight back to South Africa, because that's where he was, and speaking to my siblings saying, "Listen, they've got to give him some opioid. This is not right." Or even if you do some sedation, because he's dying. He's got septicemia. It's obvious he's dying. Just keep him comfortable. And the team there refused to give him an opioid in case it killed him. So we were finally able to give him 1 milligram of morphine. Now, we know morphine is not ideal in advanced renal impairment. Okay? But they didn't have the fentanyl. So we used 1 milligram, 1 dose, and he was comfortable for 3 days with that. Pain. So again, the importance that we need to train the whole healthcare system on these core competencies. And that's what the LEAP is about. So we've got different versions for different care settings. The LEAP core, the most commonly taught one, about 2/3 of all courses, and that's primary care. There's LEAP long-term care, which is nursing homes. There's LEAP renal, LEAP oncology, LEAP lung, LEAP liver, etc. And we're busy adapting 4 of these to the Spanish context to see, is it relevant, is it applicable? And with a little bit of adjustments for the cultural context, it's pretty much the same. Anyway, so we've got these courses. And so most of these courses have got 3 versions. There's a classroom version, where folks come together. All of these classes, maximum of 20 to 25 learners at a time. They're all interprofessional, the courses. So the different professions come together to learn together. And there's usually a group of 2 or 3 teachers, or facilitators we call them, facilitating the process. And we use a social constructivist learning approach. So stories, narrative, experiences, cases, discussions. And so there's also a fully online version. And the fully online version has got 8 hours, it's actually less, it's about 5 to 6 hours of online learning with self-learning modules. And then you come online for 4 webinars, each one's 90 minutes to 2 hours long. And we discuss the cases, and you apply what you learned in the theory in the self-learning. And then there's a hybrid version, and the hybrid version is you do the self-learning modules, and then you come together in person. Okay. And so at the beginning of the, prior to the pandemic, the majority of the courses were classroom-based, the overwhelming majority. And you may ask, why is that? Largely because we believe bringing people together in person and being together in person has got rewards that the virtual world cannot offer. But looking back, we're perhaps too fixed on that. Then came the pandemic. And as you can see on the slide, in 2020 to 21, the orange is the all online versions of the courses. We had to pivot to the fully online courses. And they've remained pretty much dominant throughout all of this. Now, thankfully, we're beginning to see a rebalancing. It's now about 50% classroom and 50% online. Does that mean the online's bad? Not at all, because there are many healthcare professionals who cannot travel. Canada is a massive, massive country, and a lot of rural and remote regions. And this offers them an opportunity to learn. And even those in urban settings, you've got all these responsibilities. The workforce is exhausted these days, under a lot of pressure, fewer healthcare professionals having to do more and more work. It's becoming difficult to bring people together into a classroom. In Spain, for example, today we're doing a course, a LEAP course, which is usually 2 days in person, but we're doing half a day today. Next week, we're doing the other half day. The week after that, the other half day. And the week after that, the other half day to make up the 4 days. Because that's how you're able to bring people together without disrupting the clinical work that they have to do. In nursing homes has become a big problem, at least in Canada and in Spain as well. There are just not enough folks. If you bring people out to go study in a classroom, who's going to do the work at the bedside? So I think the point here is that both are needed, and we've got to choose the right method for the context and the needs at that moment. But this did provide us a fantastic opportunity to compare classroom learning with online learning. So, and we'd use the same tools. So before we do a pre-post approach, the tools are actually learning tools. It's a knowledge quiz, it's an attitude survey, and it's a comfort survey. And the idea is that people do it before the course to generate reflection and a self-evaluation. They were not designed to be evaluation tools. And then immediately post-course, they do that as well. But obviously, the data, we collect the data, and we can then use that to assess and see if there's an impact. And so the study we did was we compared classroom LEAP core, just the LEAP core version. Classroom from April 2015 to March 2017, there were 244 courses, a total of 4,636 learners. And then for the online, it was April 2020 to March 2023, 458 courses, 7,471 learners. So these are big numbers. And oh, sorry, there was something went wrong when I cut and pasted this. Anyway, we'll walk you through it. at the end of the courses, we do an evaluation. It's a standard evaluation, the same evaluation for the online and the classroom. And we asked the question, overall, was the course a good learning experience? And by and large, across the professions, remember these are interprofessional courses, very highly rated. So on a scale of 1 to 7, 98, 95% of the people scored it as good or very good, so the top 2 of the scale. Now look at social work is a little bit less, especially with the online. You start seeing the level of satisfaction dropping a little bit with the social workers. And you may be asking yourself, why is that? Okay, for the social workers in the class, in the hall, in the room, you can start reflecting on that. We also ask them, is this course relevant to your practice? Because if you bring in different professions together, what you want to know is whether the course is relevant for the different professions. It's not easy addressing all the learning objectives for each different profession. So we ask, was the course relevant to my practice? And overall, very positive. Doctors, nurses scored it very positive, very relevant. Pharmacists, interestingly, the online they found more relevant than the classroom. And when we asked them, why is that? They said, well, because on the online I can personalize it. I'm going to go lightly on the psychological stuff, but I'm going to go more in depth with the pharmacological stuff. So you see that aspect of personalization coming through. And then the social workers, it was much lower, 72%, 63%. And when we asked them, why is that? They said, first of all, we prefer classroom because our profession is very much of a dialogue interaction. It's a person-to-person work that we do. And we don't need to learn about the opioids. We don't need to learn about these other things. Although when we interviewed them, many of them said it was very helpful to understand these things. It was helpful to understand what delirium is. So now we can recognize delirium. So clearly there's aspects of the course that does resonate with the social workers, but the question is then how can we improve that learning experience? So we've developed these standalone modules for social workers where they can go and do more in depth either before the course or after the course. So we're going to see if that's made a difference. The online learning experience overall very positive. Many still say they prefer the face-to-face learning, but they acknowledge that it made access to learning available to me where it wasn't, particularly during the pandemic, or I live in a remote region. There's no ways I could come to a classroom. They enjoyed the learning format, the online and the flexible learning. The pre-learning, those self-learning modules they can do in their own time, at their own speed. They can go read in more depth if there are things that they don't understand. Anyway, the areas for improvement, one of them was they wish they had more time. For the webinars, more discussions, because the webinars are only about 90 minutes long to 2 hours, and there are only 4 of them. So they've said, we love that interaction, speaking to other folks online and learning from each other. The one thing that irked them a lot is when people switch off their videos. And then it's like there's a silent void, right? But if everyone switches on the video, you've got bandwidth issues in some places. So it's that balance, trying to find that balance. I'm not going to bore you with the results, but just to say that when we looked at the classroom courses, significant improvements across the professions in knowledge, pre versus post. Similarly for attitudes, pre versus post, and for self-perceived comfort, pre versus post. We also found with the online learning significant improvements pre versus post across those 3 competency domains. And then when we compared the online and the classroom, they were almost the same. The results are pretty much the same. So in terms of, is it having an impact on knowledge, attitudes, comfort? From our work, it looks like it's the same in terms of the changes in knowledge, attitudes, comfort, and they're significant. I'm not going to, just as to show that we did do the studies, and there's some numbers if you want to. We also explored the commitment to change. So we explored what are they committing to doing after the course. And then 4 months later, the learning management system sends them automatically an email saying, you know, 4 months ago you did this course and you identified the following 4 things that you'll be doing differently in your practice. Of these 4, for each of them, were you able to implement it or not? To what extent? And give us examples of the impact. That's an indirect way of looking at impact in practice. And we've got thousands and thousands of stories, amazing stories. The patient was able to be kept at home. You know, I had, previously not identified the social needs, and now I realize that there's more social supports needed, etc. And interestingly, the themes identified are pretty much the same with the online and the classroom. And the most common themes were things like identifying patients with palliative care needs much earlier. Palliative care is not about only the end of life. It's across all illnesses, chronic illnesses. It's about identifying the needs of patients across the different domains. And in both cases, about the same implementation rate. So about 75% of the commitments are actually implemented into practice. Now, the interesting thing, there's a flip side to this information, is that when they weren't able to implement it, we asked them, why were you not able to implement it? And so we've got data on why were they not able to implement it. And do you know what the top one is? The 2 top ones? Other colleagues that I work with don't know about palliative care, and there's a barrier. And our managers, our leaders don't know about palliative care. So it's got to be a bottom-up and a top-down process. So I won't go into that. Just to say, it's very challenging meeting all the needs of all the professions in the same course. Now, in Canada, British Columbia, for example, identified the competencies inspired by, as I said earlier, the Nova Scotia competencies, which were inspired by the Irish competencies. And then someone did a study where they compared the competencies for the different professions and the LEAP courses and other courses. And they said, oh, you know what, if you're a social worker, you go to that course. If you're a therapist, you go to that course. If you're a nurse, you go. The problem with that is that you're now throwing people into their silos. So we've got to find a way of bringing people together, finding some common ground. And that's what we've been trying to do now for 25 years with the LEAP courses. And I think that online learning now can give us like plugins where we can be a little bit more specific with some of the professions without sending them off in different directions to train. This is a map of, this is 2021, of the courses done across the country. So actually these are the, yeah. So you can see it's spread across the country. Some of you may be saying, why is it all in the south? Well, because 80% of Canadians live within 200 kilometers of the American border. Further north is way too cold and pretty remote and difficult. But we still have some up in the north. Now, you may be asking, how did we get so much dissemination? Because it's not Pallium Canada that's doing all the courses. We bring together experts from across the country. It's a community of experts from across the country, different professions. We've developed the courses together. And then they spread it, and other organizations spread it. The Alberta Palliative Care Association spreads it, organizes the courses, and uses them. The nice thing about it is that you don't have to reinvent the wheel. You've got a product, and then you just take it off the shelf and you go, and the focus then becomes on disseminating and spreading instead of reinventing and innovating again. One of the scale strategies we used was this whole idea of others organize the courses, coordinate it, and give it. During the pandemic, when the workforce was so depleted, and a lot of these organizations, hospitals or primary care networks in different parts of the country, were not able, they needed the training, but they weren't able to muster the resources to organize the training. They asked Pallium Canada, please do the training. organize the courses and do the training. We've got 800 certified facilitators, mostly in palliative care, doctors, nurses, social workers across the country. So if there's a course, for example, in Calgary or in northern Alberta, we're going to find who are the closest facilitators there. Why? Because one of the goals of the LEAP courses is to connect the local palliative care specialist teams with the local folks so that you can start collaborating together. So that's one of the very, very big goals. When the pandemic struck and Pallium Canada had to start organizing the courses, we lost some of that. And so we've been asking ourselves, okay, what's happening now? Who's organizing the courses? So during the pandemic, a lot of the courses were being organized by Pallium. What's the impact of that? There are learners from across the country. There are facilitators from different parts of the country. So we're losing that piece about the local team, connecting the local palliative care specialist teams with the primary care, etc. So we're keeping a very close eye on this because we want to get a balance again to make sure that we can build capacity across the country so that local teams are developing and delivering these courses so they can connect to local teams. Palliative care clinical rotations. I'm almost at the end now, literally and figuratively. So, we know that clinical rotations are extremely important. And in fact, there's some guidelines that say, if at all possible, students and medical students, nursing students, etc., should have the opportunity for experiential learning in a palliative care environment, right? Okay, that's all good. But I think we sometimes need to stop and ask, what are the learners learning? And who's teaching palliative care? Because I think we tend to think of only us as palliative care educators as doing the teaching. So there was this fascinating study that was published a few years ago, and it was done by Ramona McTanney. So this was in Toronto. Now, Toronto is known across Canada as a place where there's very little, in fact, almost nothing, with one or two exceptions in terms of the zones of Toronto, of primary palliative care. Most of the palliative care, if not all, is done by specialist palliative care teams. As I said, except for places like York, which is an area of Toronto. The rest, it's all specialist palliative care teams. So Ramona did a study with family medicine residents who do an obligatory palliative care rotation for a month. So you would say that's fantastic. They are getting exposure to palliative care and they're training about palliative care. Who are they doing the rotation with? They're doing it with a specialist palliative care team that takes over all palliative care, whether it is specialist level complex or whether it's primary. What did the students say at the end? Oh, we learned a lot about palliative care, but we are not going to do it in our family medicine practices. Why not? Oh, it's too specialized, it's too intricate. No, it's only palliative care people that can do it. How on earth are we going to scale up access to palliative care if we're going to be continually relying on small groups of palliative care educators and clinicians to do the teaching? So I think what this tells us, we've got to sometimes stop and ask exactly what we're doing with the old. Are there things that are there unintended consequences of this? And we should maybe be building others' capacity to teach palliative care. We should be going to the residency, the clinics where they do these, where they're doing the family medicine rotations, training them on the palliative care approach so that they can see their own supervisors providing primary palliative care. We've just been doing that now at University of Navarra, where we've trained the nephrology team to do primary palliative care, and they're teaching palliative care in the nephrology curriculum in the medical school. And the residents are coming back and saying they're seeing it happening. So the power of role modeling. Why is this important? Because we can't rely only on specialist palliative care. This is a paper we published last year saying that we've got to build up this foundation, this pyramid of primary palliative care as well as specialist palliative care. And we cannot rely only on the top piece on the left because that's very flimsy. Patients will not get access to it. And so part of our training and our education endeavors need to make sure that we're building up this primary and generalist capacity across the healthcare system. Okay, just to end off with then, humanities we've found very, very helpful. This is a course that we do at the museum. We're lucky to have a phenomenal museum at the University of Navarra. So we use the arts amongst others. There's some phenomenal, massive big photographs of the gypsy people, I think Roma, right? In Spain, it's called Gitanos. Lot of prejudice and bias against Gitanos, and so we try to address that by using art, for example, to address this. We use the different art for them to look for signs, holistic approaches. In the right-hand diagram, it looks all very, very complex and all over the map. But can you see there are patterns? And so part of the art of medicine or nursing, etc., is to identify patterns. So if you look here, you can see it's actually a circle. There's another pattern here. There's a pattern here. So students find this very effective. There's a beautiful piece of art which, if you approach it from one end, looks like a walnut. But if you approach it from the other end, it's actually fingers. So what we do is we bring the students in and we make sure some of them come in from that side and some come in from that side. And then we say, look at it and reflect on it. And then, okay, what do you see? Oh, we see walnut. And the other group says, no ways. These are fingers. No, there's no fingers. That's a walnut. Anyway, the point is that we can all be looking at the same thing and see different things. And that's part of cares for every patient. And using the arts, using movies, the humanities, using reflections, as I said earlier. I think these are all powerful tools that are not new as such, but still very effective. Gamifications. Now, this is where I think AI is going to be very effective. We're going to be seeing more and more ability to do complex games, working as an interprofessional team. And so I think this is where it's going to be very interesting, what lies ahead. This is an escape room experience that we developed at the University of Navarra. And we use it to teach non-healthcare professional students. So every year there's an optional course with about 50 to 70 learners from architecture, engineering, law, and it's part of our Compassion Community Drive. And so it's an escape room. It lasts for about an hour. Groups of 5 or 6 students come in. In the first room, they get introduced to someone called Ricardo. Ricardo is an artist. And then Ricardo invites them through a video. Well, it's filmed. Please come and visit me. Come and visit my studio and get to know me. So they go into his art studio and they're looking for clues as to who he is. So the whole idea is to look for understand the other person, what their wishes are, what's important for them, etc. And so they learn clues about empathy, about learning about the other person. And then in room 3, they come into a physician's waiting room, and there a video comes up, and it's the doctor saying Ricardo actually has got ALS. And then in the room, they look for letters written by Ricardo and written by his partner, written by family members about what the experience has been like. And then they put that together. And then, so with these clues, they go to the next room, and the next room is the palliative care room. And this has been very, very effective, very helpful. I'm going to jump over this and just come to an end. So basically, I think the new is not necessarily better than the old. I think we can embrace the new technologies, but we've got to understand the limitations. We'll be part of developing them and not waiting for others to develop it. And we need to have all of these things in the toolboxes, and we need to then choose the right instrument for the job at hand, unlike these folks here. So this is examples of the wrong tool for the job. On the left-hand side, imagine the poor baby. Imagine if the dad and mom go in opposite directions. You'll probably jettison the baby. The one in the middle is fascinating. This was in the early 1900s, and they put these fire alarms in New York. But then people were sending false alarms. So they thought, okay, we're going to stop false alarms by putting this contraption in where, in order to activate the alarm, you're going to put your hand through it, and when you activate it, this thing captures your hand. And then the fireman comes along and they will release you from it. So can you imagine, no one's going to put their hand in there to I'm stuck here now, there's a fire and I'm stuck here now. And then obviously the one on the right-hand side is just not the right tool for the job. Thanks very, very much. Sorry.
Thank you so much, Jose, for a very interesting and challenging and stimulating presentation. And what's wonderful is that the other speakers this afternoon are going to speak to some of what you mentioned, but also some of the innovations that are addressing some of the concerns that are rising. We have some time for questions, and if you just raise your hand, there are microphones that will roll. If anybody has any questions for Jose. Just hold for the mic.
Okay. Thanks for an excellent presentation. I actually have 2 questions. So the first is just in the kind of context of sustainable energy, sustainable healthcare. AI is a massive consumer. That's one thing. Has there been any studies on that? And the second one is, you know, there is a risk that with AI, there would be kind of using AI to learn how to communicate with each other, you know, asking what should I say here, and there's a risk of it dehumanizing us. Is there any kind of safeguards in place to prevent that or to manage that?
Yeah, great questions. The first one, when we started developing these pictures, these photos of the people, we thought, okay, great. And then someone on the team said, you know what impact this has? And we went and found some studies on, for each of those images generated, enormous amount of energy and carbon footprint goes into generating just one of those pictures. So in the team, we said, okay, we've got to limit this only when it's absolutely essential, and reduce it, because it's so tempting just to go quickly, oh, can you generate a picture of this? Can you generate a picture of that? Can you generate a picture? So I think education is extremely important. Say, listen, so there are some studies, but I can't quote those studies. But I think we'll be seeing more of those. And I'm sure many of you, especially in rural regions, are beginning to see these centers popping up with all the and energy sapping centers. So I think it's a big problem. In terms of the dehumanizing, I think it's very real. I mean, we're beginning to see things like, I was looking at BBC recently, where some people are using AI to speak to God, you know, or their friends. I mean, you're getting into these illusions that you're speaking to someone who's real. And yep, I think there's a very high risk of dehumanizing. And one of the questions we should have is how can we positively influence that, so we don't end up dehumanizing. And I think part of it is education, a very big part of it.
Thanks very much for a very interesting talk. Ellen Stewart's my name, at GP, and a lecturer in medical education to undergrad GP or undergrad medical students. I'm interested in your thoughts on the reflection piece and the how you've adapted your assessment. We had similar issues, and actually with personalised reflections, AI was still being used. So we've actually modified now, and we're in the process of creating an interactive oral assessment for our medical students. So we've abandoned we're still doing, MCQs and that kind of thing, but in terms of assessing reflection, we're doing it in an oral format, and we're piloting it at the moment, but we're starting it in the new year. And I was just wondering about your thoughts on, it's labor intensive, and we've had about 4 pilots already to try and get it efficient and right, but it's expensive and it takes manpower and it has to be reliable. So there's a lot of examiner education. But I was just wondering what your thoughts were on interactive oral assessment.
I think that's a very good point. And in fact, we're moving our reflections to when they do their clinical rotations. And what I forgot to mention was that before uploading it, they have to discuss their reflection with their clinical supervisor, and the clinical supervisor will review it. What we're trying to do now is train the clinical supervisors on giving feedback and trying to identify red flags when it may have been generated by AI. But I think you're spot on, and we're trying to do. I don't know if we've got the resources to do orals throughout all the 6 years of training. So we limiting it now to during their clinical rotations, where the clinical supervisors become. So that's the first filter, and only after that, when they sign off on it, then they upload it. Yeah.
Just comment. You mentioned in your talk about when we're using online examinations and students are using AI while they're doing that. Where by university we've introduced a system where if it's an online exam, it has to be done on campus, and we have a piece of technology that actually blocks everything. It's called Respondus. It's been trialed this year. It's been trialed this year, and it's Respondus. It's called. So, but the only thing is that if you're using online examination, they have to be scheduled on campus, because the technology has to be used on campus because of the licensing. Yeah. But if it's something that we can see, will it be of value?
We do the exams as well on the campus, but we haven't been applying this software.
It's relatively new, so that's why we're trying it this year. But I'll keep it first. I
Thank you.
Time for one more, if anybody has a question or even a comment.
I'm overstaying my welcome. Thank you very much.
Yeah. No, we have one. Yeah.
Sorry.
Just get the mic to you. Just stick up your hand.
Thanks, that was really interesting. My name is Tracy O'Carroll, and I'm with the Health Information and Quality Authority, but we run national surveys, and we ran one around the National End of Life Survey, and it was really interesting. But I found two things very relevant for us. One is the languages, and how are you using AI to translate into those languages, both on your learning platform and in your other work?
Yeah, so we're adapting the LEAP courses from Canada to Spain, right? So we thought, okay, we'll use one of those programs, DeepL, to do the translations. It helped get the process going, but it's nowhere near perfect. We had to do a lot of fine tuning. For example, it gets confused between Latin American Spanish and Castilian Spanish of mainland Spain. Some of the nuances are lost, are translated literally. So we still had to put a lot of work into going through everything. But I mean, I'm sure it saved lots of hours of the initial translation stuff. But you can't just do the translation and walk away and say it's done. No ways. Yeah.
Thanks again, Jose. Thank you. And I'm sure Jose will just talk to the